Mute. I think I'm good to go here. All right. Welcome, everyone. Thanks for coming. As we get started here, this is going live here. You can ask me just about anything. Hopefully we won't have, I got a different camera this time. So hopefully we won't have the voice lagging issue that we had before. Before we get started with questions, I wanted to make a couple of announcements. So the first one, and I'm going to share my screen for this. Give me a minute here. All right. So the first announcement is I created, back when I started making videos in 2018, I got the big idea to edit my videos with music. And I have a number of them that people complained over the years that you can't hear what I'm saying because it's distracting. So what I did was, now YouTube allows you to go in and not edit out. You can replace video. It's kind of for the purpose of putting like foreign language tracks in, but you can put in a separate English track. So I took several of the videos that had all that loud music in the background, and I made a separate playlist. So if you go to my site, my channel, go to playlists, it's called Listen Without Loud Background Music. Try to make it pretty obvious. If you click on that,
I'm Dr. Tracey Marks, a psychiatrist, and in this video, I'm going to...
Okay, you can hear the music already. So what you would do if you come to this, so this is the playlist with all the videos that I changed out the audio. There may be a couple others, I just haven't gotten to those yet. If you click on this settings gear, it's not a wheel, a gear, and you go up and see audio track, there's 2 of them now. Before, I don't even know, for the other videos where I didn't do this, I'm not even sure this audio track will show up if you click on the gear. So it only appears if there's an option for you. So here you see it's English original. Then if you click, now you can go to the second one. So this is the original. Most of them will say English United States. I think one of them, it says something else, descriptive audio or something like that. You click on that one and then click the gear to get out of it. And then you can see,
I'm Dr. Tracey Marks, a psychiatrist. And in this video,
no more music. Yay. So all of these videos in this playlist have had that done to it. So that's how you would view those videos if you're interested. And just because, and this is my buddy Daryl here, who's helping me out. You can say hello to Daryl. So that's one announcement for those, because the information's still good. It's just bad editing. I was doing the editing myself back then. Another thing I wanted to announce is for those of you who have been to my mental wellness space store, it's mentalwellnessspace.store, and have tried to get these tumblers. It says sold out. This will be rectified by the end of March, but I had a quality issue with the company that was making these, and I didn't like the quality. So I have had them made at a different place, and it takes a while to get that stuff shipped and all of that business. So I will be replenishing these in the store. I use them myself. They're very good. You can't tell from here, and I'm going to put some better pictures up too when I get those in. But it does have a sliding top. I know I don't like tumblers where they're not spill proof because you can't close the top. All right, so that is that. I'm going to stop sharing my screen now. And then the last thing is, before we start the questions, is this year, 2024, I have made more of an effort and commitment to have an email newsletter that brings you quality information and tries to keep you up to date on what's going on in the world of mental health. Sometimes there may not be anything exciting going on, and sometimes there is. So if you want to stay up to date on mental health information, then sign up for my email list or my email newsletter. And you can get that sign up at getmentalhealthtips.com. So if you just go there and you can sign up and be on your way and look in your inbox for me. All righty. That's it. For my part, I'm ready for you. So let's start with the questions. Okay, so Kristen says, your thoughts on Abilify for bipolar depression? Thanks for your question, Kristen. My thoughts on Abilify. So I think it's okay. Well, I shouldn't say it's okay. So before we had some additional options like Latuda and now Caplyta, Vraylar, Abilify was the go-to drug. At least for me, it was. I thought it did a very good job with both the depressed phase as well as the manic phase. I do think Latuda is a little bit better. It is FDA approved for bipolar depression, Latuda that is, and that's its main area where it does its best. Doesn't mean it won't help with mania, but that's kind of what it was FDA approved for. But Abilify, yeah, I think it's a good drug still. I still use it quite a bit. One of the things about it though is it is one of the ones that's supposed to cause less weight gain, and as such, it tends to be more on the activating side. So medications that aren't in activating meaning like it can cause akathisia. What is akathisia? Akathisia is an abnormal movement where you can feel restless or feel like, like you've got ants in your pants. You just have to move around and be very unsettling and disturbing for people and keep some people awake. So Abilify tends to be more on that end of causing akathisia. Usually the higher the dose, the more chance that you'll have side effects, but cause less weight gain. Medications like Seroquel or quetiapine, which is also FDA approved for bipolar depression, tend to cause more weight gain. It is more sedating and so less activating. So you don't get the akathisia so much with it, but it can help you sleep. That's where the sedating side effects can be a benefit, but it's also more prone to weight gain. So if you are looking for something that is less likely to cause weight gain, then I think Abilify's a good choice that way. All righty, next question. Good morning. Thank you. Thank you, Mind Biz. Well, that's a long one. I got to put on my glasses to see that. Oh, minding my business. Minding my biz, being nosy. I love that. Great. Thank you. Hi from Poland, from Parallax. Thank you. Welcome. Welcome. Aline, hi from Brazil. Thank you, Aline. All right, Kenneth. Oh, wow. Thank you so much for the super chat, Kenneth. Kenneth says, I really appreciate it. Do you have any thoughts on how to reduce long-term benzodiazepine tolerance if you're taking them long-term, regularly, but infrequently? Think 10 plus years at a starting therapeutic dose with a 30 count prescription lasting approximately 6 months. So I take it that you're saying that when you do get a prescription for 30 pills, it lasts you about 6 months. And I think actually that is a great use of it. I will tell my patients that, they'll say, well, can I just get a prescription for Klonopin? And we'll talk about not using it all the time. And I said that, well, hey, and they'll say, so let me back up a little bit. So I think use that is less likely to lead to dependence, not tolerance. So there's a difference. So I'll get to the tolerance in a minute. Dependence is where you cannot miss the dose without having significant side effects. So you get withdrawal effects if you stop taking it or miss doses, you're less likely to have that happen to you where you can't go a day without it if you take it about once or twice a week. I think 3 times a week is kind of on that border, because then 3 becomes 4, 4 becomes 5, and then it's just daily after a while. If you figure that you're taking it twice a week, that's 8 pills a month, and 6 times, that's 8 pills a month. So what's that? 3 months, that's 24 pills. So a 30 pill prescription will only last you 3 months and some change. So if it's lasting you okay, there we go. I got blurry for a minute. If it's lasting you 6 months, then that means you're taking it on average once a week. I think, which is 4 pills a month, and then 6 times 4 is 24. So taking a benzodiazepine once a week has low chance of causing dependence, because you're going, 6 days without it and then taking it again on average, let's just say. Those 4 pills could also mean that you take it 3 days in a row and then don't take it anymore for the rest of the month. So it doesn't necessarily have to be once a week per se. So getting back to your question of tolerance. So tolerance, it's taking it infrequently also reduces tolerance buildup. So tolerance is where your body gets used to the effect, and the effect is not as great anymore on that same dose. So you have to keep going up on the dose to get the same effect you had before. So you take 0.5 milligrams, and that works for your anxiety. And then after a while, you're noticing it's not quite working well enough, and now you take an extra little half. Now you're taking 0.75, or you just take 2 of them, and now that's what you need, and that's your new dose now, because 0.5 doesn't work anymore. So I will tell people, or suggest to people, that not only do they not take it daily, or if, let's say, you're taking it for sleep, if you take it for a stretch of days, like 3 or 4 days in a row, then you take a break from it and see if you can go several days before you need to take it again. So breaking up how often you take it, helps deal with both tolerance issues of kind of stringing along how long it takes before you need to move up to that next dose, as well as dependence issues of developing withdrawal if you miss the dose. There are some sleeping pills. Not all of them are benzodiazepines, but I'm kind of throwing that in with this question. There are some sleeping pills like Zolpidem, Ambien, where you don't have to take it every day before that dose doesn't seem to work as well anymore, because the sleeping aids are notoriously stop working after a while, because you're relying on a sedative effect for your therapeutic effect. Well, medications that cause sedation, even though, oh no, what happened? Sorry about that. Oh, I had something kind of just pop up on my screen. Even though we're trying to, for sleeping aids, we want that sedating effect. All side effects, like sedating side effects, many of them will go away over time, because if you take something where we don't want it to be sedating, but it goes away after a few days. That's what we want. We want that to go away. So all that to say is, it's hard to get sleeping pills to last consistently for a long period of time, taking at the same dose. And oftentimes you'll have to take a break from them to reduce the tolerance effect and have that same dose work again. So I hope I didn't confuse you with my answer. Kind of the short answer is, really the way to reduce tolerance is to take it not that often. So have stretches of time in between the doses, and not take them every day. It sounds like you're already not doing that. And if you're still developing a tolerance, despite the fact that you only take it once a week, It just may be the nature of that medication. As I mentioned, Zolpidem, you can take it twice, and then the third time you try and take it, it doesn't seem to work. And then you got to kind of give it some time before you go back and take it again. So there isn't a good answer for, I don't take it that often, but I still am developing tolerance. There really isn't a good answer for how to have that not happen other than taking a break from it. And you can do that if you're only taking it once a week. All right, Ella, hello from the Midwest. Hope everything is doing okay. Everything is doing okay. Thank you, Ella. All right, another super chat. Thank you so much. From MP, let's talk about it. Hi, Dr. Tracey. I've been diagnosed with anxiety disorder and a little bit of OCD. What is the best way to decrease those conditions to low or minimum? Anxiety and OCD, decreasing the condition. So that is a very long answer, MP, because there's lots of approaches to addressing anxiety and OCD. So, with anxiety, if you're looking at non-medication options, you're talking about doing things like practicing mindfulness, which is being in the present moment. And it also what you do for your anxiety also depends on what kind of symptoms you're having. So some people have a predominance of physical symptoms, and some people have a predominance of mental symptoms. If you have a predominance of physical symptoms, like you feel chest pain or tightness, or just feel kind of on edge, that's where things like breathing exercises, practicing mindfulness, that's where those things can help with those physical symptoms. Things that activate your vagus nerve. Your vagus nerve works the opposite of your adrenaline system, the fight or flight system. So if, someone busts through this door, my heart's going to race. I'm going to feel scared. I'm going to be like, who is this? Someone trying to attack me. That's the normal response. With anxiety, though, you can have that response just waking up in the morning. And so that's an adrenaline response. And the opposite of that is putting the foot on the brake to calm things down. So your vagus nerve kicks in when your mind realizes the threat has passed, and now we need to slow things back down. Well, you can trigger your vagus nerve or trigger that system of slowing things down with vagal maneuvers. I have a video on my YouTube channel giving more detail about that. But these would be things like splashing cold water on your face or chest, because that temperature, that quick temperature change triggers a vagus nerve. Breathing exercises work in part by activating your vagus nerve, of slowing your breathing, because when you get anxious, we tend to hyperventilate, and not necessarily huffing and puffing and losing your breath, but just breathing at a faster rate. So if you try inhaling and exhaling in a span of like 6 seconds, like inhale for 3, exhale for 3, that's a 6-second cycle. And that's like, and you can get like 10 of those in a minute, which is still significantly slower breathing rate than you would just kind of at rest. An average breathing rate at rest might be like, I don't know, 15 breaths a minute or something on average. But if you force yourself to slow your breaths, that can trigger a relaxation response. As far as addressing OCD type symptoms, that is multifactorial, as far as like whether you're trying to address the mental obsessions versus compulsions. So if you are someone who, let's say you get tense or anxious, and now you have to feel like you got to start checking stuff. I'll do that when I get anxious, going on a trip. afraid I'm going to leave my ID behind and get to the airport and not be able to go somewhere. I start checking stuff, check my ID about 50 times. Anyway, one way to reduce that is called exposure therapy with response prevention. That just means you expose yourself to the thing that triggers, say, the anxiety or the tendency to do whatever compulsion you're doing. So for me, let's say it's checking my ID, and prevent yourself from doing that. So I would make myself, like, let's say I, manufacture this or act like I'm going to the airport or something that would make me worry that I'm going to forget something. And I would force myself not to check 50 times, because the checking is not just for the purpose of, sometimes you do need to check, once or twice, and then you're done. But the checking for some people can become a self-soothing mechanism. And so you're still checking and you know that it's there. Like, let's say it's the ID issue. The ID is there, but you're checking because you're anxious and it's making you feel better. Well, that feeling better is a temporary improvement or a temporary feeling better, because what you're doing is you're reinforcing the anxiety by continuing to check, even though intellectually you know that you don't need to check. But that checking is making you feel better, and you're reinforcing the problem that way versus breaking that pattern of not letting yourself continue to do that. So that's just kind of a quick and dirty answer of some of the things that you can do. I have a book, Why Am I So Anxious? And you can find it on Amazon, and it has several activities, self-help related activities that you could do to address anxiety. And it even has a section in the back that gives you some ideas of all these tools I just explained. When do you use them? So for this, you use that. For this, you use that. And so I think that would be a great resource for you to go to look at what you can do for the kind of anxiety that you have, because what you do depends on what you're experiencing. And what works for one person doesn't necessarily work for the next person. So check it out. Why am I so anxious? All righty. Hi, doctor. Love your videos. Thank you. Thank you, Captain. Appreciate that. All right. Let me put my glasses on again. I love Dr. Marks and have recommended her channel to many people. She is great, and I've got a lot of great advice from her. Thank you. I don't want to, Boyardee. I know how to pronounce that chic, though. Thank you for that. Appreciate it. All right. Elizabeth, thank you so much for the super chat. Is it possible for a bipolar person to only have one manic episode in their entire life? And how do you feel about bipolar people who go off their meds under medical supervision? Thanks for that. That's a great question. What do I think about someone who only has one manic episode? So here's two thoughts. One is a couple of thoughts. One is, was the manic episode real? But let's just say it was. Okay. You could have a manic episode that is not from bipolar disorder, but is induced from something else, like thyroid disease. An overactive thyroid can give symptoms at manic mania. Certain medications. People can have a manic episode or manic-like episode from steroids. You could have, some kind of infection or inflammation and get a round of prednisone steroids. Now, usually the oral steroids don't do it as much as intravenous steroids. So if you had some serious allergic reaction, went to the ER and they gave you some IV steroids, you're more susceptible to that kind of reaction. And there's some other medical conditions that can cause manic-like symptoms. So that's one explanation for how someone could have a manic episode and then never have another one. Another explanation could be you have a manic episode and then subsequent episodes are hypomania. Hypomania is like a lesser or less severe form of mania, but it's still above your baseline. So you're still sped up in some way that generally causes some level of dysfunction, but it may not require you going to the hospital, let's say. Or you still may be able to work through it. So you may be moving fast, talking fast, thinking fast, not sleeping that well, like maybe only sleeping 4 hours a night, but that 4 hours a night is enough for you to function. And then it just kind of blows over after a week or 4 or 5 days. So, so you could just have that hypomanic period come and go and it not be noticeable enough for you to say, oh, okay, had another episode kind of thing. If you ever have one manic episode, it's still considered bipolar 1 disorder, even if subsequent episodes are hypomania from that point forward. What's the distinction, or why does it even matter whether we call it 1 or 2? It's generally because it has to do with the outcome or what we expect to happen from that point forward, with manic episodes being more severe than hypomania. Bipolar 1 people tend to have more circumscribed episodes that have clean separations between the episodes. Whereas with bipolar 2, there is more of a tendency, not everyone, but more of a tendency for people to spend longer periods in depression and have their depression episodes just kind of not seem to have a real start and stop to them until they get out of it and go straight into mania or hypomania at that point. Or for bipolar 2, it would be hypomania at that point. So the 1 versus 2 distinction kind of has more to do with the trajectory of the illness and what it's expected to look like. So that said, still, so if you have one manic episode and then never have another, but all the rest are hypomanic, it just means that even though you would technically still be bipolar 1, your trajectory it may look different than someone else with bipolar 1, because you really aren't having manic episodes anymore. You're having hypomania and having probably longer periods of depression. There was a second part to your question. Daryl, can you put that back up? And the second part was, how do I feel about bipolar? Oh, going off. Yeah. Okay. So, the second question, let me just go ahead and repeat it, is how do I feel about people with bipolar disorder getting off their meds under medical supervision? I think the caveat here, the key phrase is under medical supervision. I'll speak for my own professional experience. I support certain patients of mine going off under medical supervision, going off medications, depending on their history of episodes. So, I saw someone years ago who her history was she had a manic episode every 7 years and hardly had any depressive episodes. So I saw her during one of her manic periods, and haven't seen her since. Now, we didn't plan for her to get off medicine under supervision, but if you think about it, if going back to the circumscribed episodes of having an episode and then a recovery, and then an episode, and then a recovery, that recovery period could last, if that lasts you a year or 2 before you have another episode, then yes, it could be of benefit for you to get off medicine and reduce, the load, the medical load, the side effect load of those medicines, especially if they cause weight gain and things like that. But if you were to do that, it's best if you have had enough experience with your illness to know what your prodrome symptoms look like, or what it looks like when you're starting to have an episode. Prodrome symptoms would be the symptoms. Really, the prodrome symptoms are, a prodrome is like the symptoms that come before the full-blown illness manifests itself. So we don't know necessarily that you've got bipolar disorder. You just have before you get diagnosed, you have some anxiety and some depression and some kind of anxious depression, and something just doesn't seem right. And then boom, you have a manic episode. Now we know what we were looking at before was bipolar disorder kind of ramping up. But still, we'll loosely call prodrome symptoms as well, symptoms that you can have before another episode. So let's say some of, typical things might be affecting your sleep. So you start noticing that you're not sleeping very much. You normally sleep 7 hours a night, and now you're only sleeping 5, and you're not feeling tired. You're just kind of waking up. That might be a sign that, something's getting ready to happen. That would be a time to talk with your doctor and see whether or not you need to get back on medicine, or just need to get back like on bipolar meds, or just get on something for sleep to help kind of dampen down what's starting to build up, because bipolar disorder is very sensitive to changes in sleep. And so you could kind of kill off a manic episode from coming if you could just get some sleep. For some people, not everyone, but some people, if you get it early enough, it's like you can stop the fire. Sometimes I had a patient who told me that they could tell that their mania was coming when they started this was a musician, and when they started coming up with all of these intricate musical ideas in their head. And then after the episode was gone, the ideas that they had weren't very good. So it wasn't like, this wonderful creativity of creating mind-blowing stuff. It was just random creativity. But that's how this person could tell it's getting started. Now, notice I'm talking mostly about mania, not depression. I think early signs of depression would be longer sleep. It's getting harder and harder to get out of bed. You're starting to think more negative about stuff, and it's harder to manage or police your own thoughts. Usually you need to engage someone who's close to you to help you notice thinking changes that could help you also identify when you're starting to change. So long story short to this question is, I think if you're going to consider getting off of medications, it should be because you normally have long intervals or decent amount of time in between episodes. You have an inter-episode period where you don't have very many symptoms. You don't just go from one episode to another one, from depression to mania, and then to depression again. You do have a clean period of time where there's nothing going on. And you have someone in your life to help you recognize behaviors or thoughts that you have that are indicative of an episode coming, whether that's hypomania or depression, to help you to help you get a head start on the progression of symptoms. So you can get back in with your doctor and stop things before they ramp up. Those would be the scenarios where I think someone could safely pause their medication for some period of time. And how long that period is depends on your own history of how long you normally go without symptoms. Thanks for that question. Pierre, hello from France. Thanks, Pierre. It seems like a very French name. Lindsay, LPC here. Thanks for all you do. Thanks, Lindsay. And thanks for all you do as an LPC. Rodney, off topic. Why decide to become a psychiatrist or regular MD? Also, what other career paths had you considered? Thanks, Rodney, for that off topic question. It's fine off topic. Or actually it is on topic. So I actually graduated from college with a degree in electrical engineering, and I worked a year for what was then Arthur Andersen, then became Arthur Andersen Consulting while I was working for them, and then they later became Accenture. I spent a year working in that environment. And while I was doing that, I decided I wanted to go to med school. I had thought about med school in undergrad, but I was in the engineering school and I went to Duke University. And at that place, you just don't extend years, when you're paying that kind of tuition and whatnot. So I knew I had to finish in 4 years. And that's all my parents were doing for me, 4 years. So I went ahead, I just kind of put off the idea of switching majors and just finished off and then worked and then decided, I really do want to pursue this. So then once I got in med school, I decided my interest was in internal medicine. And I changed that to psychiatry after I did my psychiatry rotation and really enjoyed working with people, helping them mentally versus physically. And that decision came in my my 4th year of medical school. And that's the way it's been since. Thanks, Rodney, for that question. To Jesse, good morning, Dr. Marks. Thank you so much. You are welcome so much. Okay, David, thank you so much for the super chat. Can you explain why intermittent fasting, along with low carb, keto-like diet and exercise, lead to elevated sense of well-being? It also made quitting alcohol easy for me. I seem to need all 3. Very good. Excellent. I'm glad you had that outcome. So with intermittent fasting, and then low carb and keto-like, all right, and exercise. Wow. You're doing everything here. So intermittent fasting, the idea with intermittent fasting is that you are giving your mind and body a chance to do its repair work, regenerative work, and things without having to attend to digestion. So, it's kind of like, say, a warehouse type place or a Walmart. They have to close the doors at some point to allow for restocking and things like that. I guess a lot of times that stuff happens at night. So if you think of your body and mind that way, we need downtime to regenerate, restock, synthesize information learned during the day and apply it and so on and so forth. Okay. So with intermittent fasting, it's like the stop having a longer period of time for which you are taking in and eating and triggering certain mechanisms in your body, digestion and things like that. You are giving your brain more time to for self-care, for lack of a better way to put it. You're giving your brain more time for self-care. Then you also low carb. So low carb. I'm trying to think of a good direct line between low carb and brain function or wellness. So with low carb, you have less, the idea is that you have lower levels of cortisol and insulin spikes. And you have more even hormonal levels, so to speak, with the hormones here involved being insulin and cortisol. So you eat, and this kind of relates to intermittent fasting too. You eat a heavy carbohydrate load. Your body has to do more work to take all that carb, break it down, and store it. So you get, and insulin's involved in that, cortisol is also involved in that. And so you get higher levels of these hormones. Okay. Well, over time, if you eat too much carbs or too many carbs over a lifetime, you can start to get insulin resistance where so years of surges in insulin to kind of quickly break this down and send these carbohydrate units, turn them into sugar and fats and storage and all of that. Your cells, insulin receptors, become less sensitive over time, just kind of like parts wearing out. Early signs of insulin resistance are things like abdominal fat, because of the difference in the way fat is stored in the context of insulin resistance. So reducing your carbohydrate load, or reducing how many carbs you eat, reduces the insulin surges and cortisol surges. Why does that matter? Because it's not just a diabetes issue, but lots of body systems and nerve systems are controlled by lots of, are controlled by insulin, cortisol, all of that. It's just one big web of information that one system depends on another system. So it's a little too complicated to get into the effects of insulin on brain cells, but just suffice it to say is that how things are working from the neck down affect how they work from the neck up as well. Keto diet, where you have high fat, hardly any carbohydrates, and a very high fat, has been shown to be very beneficial for certain conditions, particularly schizophrenia. That's where I've seen it. The studies, I think some seizure disorders as well. Because the idea is that the fats are contributing to nerve growth and repair in the brain, because of those cells kind of feeding off a high fat molecules. And the sheath on our nerves and things, those are kind of made from cholesterol and other types of fat proteins and things. So we need fat in our diet. We need good fat. So giving your body and brain more of it is thought to help those processes, as well as you've got the less insulin not causing surges and insulin resistance. So you've kind of got a two-pronged system with the keto diet: the high fat, which our brain loves, and then less insulin and cortisol surges. So, that's kind of the high level, forest level explanation for how keto and low carb help us mentally and physically. Heavy carbs and surges with insulin and then high cortisol levels and all that not only affect you mentally, but also affect you physically as far as fatigue, easy fatigability, low energy, even low alertness, even though that's more of a neck up issue. So, but that said, keto isn't for everyone. So I do want to put that caveat out there, is that it's not a good diet for everyone. In fact, if you talk to nutritionists, some nutritionists in like nutrition schools, many of them will not support or endorse one specific diet that everyone should have. Everyone should be on carnivore, or everyone should be on keto. It's about a balance. There are some people for whom keto is very good for them. But again, not for everyone. And I think looking also kind of an overall appraisal of these diets, I think the biggest takeaway is reducing processed foods and eating real food and nutrients. I think that's where the main benefits. And then when you branch out off into whether it's keto or paleo or Mediterranean or, anti-inflammatory, all of those differences, they serve some people for certain things. Gluten-free. Some people need gluten-free and not everyone does. So, all right, I'm rambling. Sorry about that. All right, Preppy, Dr. Tracey, thanks for all you do. Thank you, Preppy. I appreciate it. Love this, doctor. Thank you, Tasha. Thank you so much. And Pierre, again, from France. Okay, Joey. Would you make a video on new studies about psilocybin and bipolar? Thanks for that, Joey. I could when I see some good information about psilocybin and bipolar disorder. Most of what I've seen is psilocybin mushrooms treating depression. And I could go on about that because I get very excited at that prospect. What gets me so excited about the prospect of psilocybin treating depression is the studies. So Compass Med is one of the companies that's kind of at the head of the pack. They're in phase 3 of their clinical trials. And then the next step, once that gets approved, is applying for a new drug application called NDA. So where am I? Okay. So they are heading the pack. And so they are showing depression being treated with one. And then there's another, I think, set of trials they're doing of people being treated with 2 doses, 1 or 2 doses. And one of the studies that I've seen, the effect or the improvement in the depression lasted up to 18 months. Now, further studies may show, further long-term studies may show that it lasts even longer than that, but at least that's what I've seen so far, 18 months. And not only that, but these people had a difference or change in their outlook. It's like opening your mind to having more flexible thinking. So not only, I know that the psychedelics, psilocybin being one of them, are acting on the neuroplasticity concept or system where it changes wiring in the brain, changes the way that the cells communicate with one another, versus replacing serotonin or replacing chemicals, brain chemicals. Okay. I've also seen some suggestion that certain of them, like psilocybin, being called not neuroplastic, psychoplastic. That's a term I just recently heard. Psychoplasticity, which is changing people's personality because of the way that these drugs can affect your psychological flexibility. If we had something like that can change people's deeply ingrained personality traits that cause relationship problems because of the way they behave and believe, that's almost like Nobel Prize level as far as I'm concerned. So I don't know if we're there yet. That was just kind of some stuff I read about, but the basis of it is sound. Of if these drugs, if it does bear out that people's mindset and attitude shift as a result of 1 or 2 pills, that could lay the groundwork for further looking into, can you change personality disorders? Can we treat personality disorders with psilocybin? I've seen also psilocybin, I think for maybe addiction, and maybe anxiety. I'm not sure about that one, but it's being looked at for several issues, not just depression, but I think depression indication is like probably the first one it's going to get approved for. And when, I'm not sure, maybe now 2025, perhaps, since they're in the phase 3, they're kind of at that last step. I know you didn't ask this question, but probably the first psychedelic, and not, after ketamine, which technically is a psychedelic, but the first one will be MDMA, assisted psychotherapy for PTSD. The company that is producing that just recently filed their NDA, their new drug application. And I read where that's supposed to be, the FDA is supposed to make a decision about that by August. They're kind of accelerating that process. So in August, we could hear if MDMA, which street name ecstasy, is approved to be used to treat PTSD. So, so we're making progress. I know this wasn't your question. You were asking about psilocybin, but from my perspective, one begets the other. So once we get the ball rolling with the psychedelics and their treatment and getting them approved, I think that will pave the way for others to get the kind of shorter route to be able to get approved faster. I mean, it can take some of these drugs 10 years in the pipeline of development or even more. Compass Meds has been working on psilocybin since early 2000s. So we're talking 20 years for them. So hopefully, these others now, there's a whole lot more research going on many of the psychedelics. So hang in there. All right, Anthony. Hey, Dr. Marks, just wanted to say I appreciated your videos a lot. Thank you. Oh, and one more thing thank you so much, Anthony. I want to make sure I actually answer the question. Will I make a video about it? Probably not right now, just because I haven't seen enough about using psilocybin to treat what would really be bipolar depression at this point. Because keep in mind, this is just kind of a small point. Treating bipolar just means that you're treating a condition that has both depression and mania. So when someone is looking at a drug for bipolar disorder, they have to pick a side. What are they looking to treat here? Are they looking to treat depression or mania, or both? Because many of the antipsychotics will treat both phases. But to kind of quickly get something approved, they'll usually pick one of them. And so since psilocybin has shown effectiveness for unipolar depression, I think if they were try and branch out, then they'd probably be looking at bipolar depression, but that still doesn't necessarily mean it would treat mania, the manic phase. Okay, next question. Okay, what? I should just leave my glasses on, but then I can't see. Jacques, I hope I'm pronouncing that right. Armstrong, thank you so much for the super chat. Your thoughts on rebuilding defense mechanisms after detoxing meds from decades of use. By the way, I find your videos very useful. Thank you. Oh, wow. Rebuilding defense mechanisms after detoxing from meds after decades of use. So yeah, so what you're talking about, Jacques, is how do you, after you've spent years with what we would call maladaptive defenses, probably with the drugs being one of the defense mechanisms, because, well, I don't want to get into a long thing about why people will use drugs. It's for different reasons. So it's not just one reason. Okay. But one of the things they unfortunately can do for you is make you not be able to rely on your own psychological defenses, because it becomes an escape. So if that's the case for you, and the drug use, whatever it was, helped you escape having to actually deal with whatever was troubling you, internal distress, external things, then it's almost like a child who's been overprotected for years, and parents didn't let them kind of face life on their own, and they're just kind of, now what do I do? I think this is something that requires or would need a therapist or coach to help you through, because you're not going to be able to see everything. You're not going to be able to observe yourself in a way that necessarily helps you change. The way to change is to be in a situation, have someone help you see how your response is maladaptive. Sorry to keep using that kind of word, but how your response doesn't help you and hurts you or hurts the person that you're around. Help you understand maybe why that's your knee-jerk response and help you do something different the next time. So from your perspective, even if you're the most insightful person ever, it's still not that easy for you to see everything. Okay. So objectively. So let's say a problem, I'll just say, use myself as a hypothetical example. If I notice that I just can't stop blowing up at people get on my nerves, and I wish I had more patience, but I just can't get it. And it's getting in the way of my relationships with people. People don't want to be around me. I think it's them, but I'm open to the fact that maybe it's me. Well, I might not be able to see that the things that are triggering me are things like, someone expecting me to do something. Well, I get mad, but I'm getting mad because I feel like what they're asking me, they're not really taking my needs under consideration. I feel exploited every time someone asks me to do this thing. Well, why do I feel exploited? The person's just asking for something. Well, it's because usually when someone has asked me to do this, I don't set enough boundaries and I do too much. And then after I do all that stuff, I feel exploited. Well, the problem isn't that person asked me to do something. The problem is I didn't set boundaries enough to keep myself from overdoing, you see. So I'm not necessarily going to be able to just kind of sit at night and figure all that out. A therapist could help me see that connection and see that, okay, well, this person only asked you to do this. Why did you do all this other stuff? Well, because I thought this and I thought this and I thought this and I thought this. Why did you think that? Well, maybe it's because I was projecting. That's what I would want them to do for me, but that's not what they asked. So you see what I'm saying? It kind of can take, sorry about my camera getting like in and out. I'm going to keep doing this. I need to get some better equipment. Okay. Anyway, I'm not going to necessarily, it kind of takes someone to ask questions, like hear the situation. And this is kind of like what could happen on a therapy session. Hear the situation. This happened. This person asked this. I got mad. I stomped off and I did blah, blah, blah. And then have that other person ask questions about my responses and my reactions. What was I thinking? What assumptions was I making? To then help me uncover assumptions I make that are wrong assumptions about people's intentions, negative thoughts I have about myself that need correcting. And then through correcting some of those things, helping me see how I can do it differently the next time. So you mess up and you make some corrections. You're still going to keep messing up, but hopefully then you get to the point where you're messing up less. Because some things about yourself, you just aren't going to necessarily be able to clear out. Now that I'm not using anything, I'll never, do whatever X, Y, Z. I won't ever do that again. No, you'll still stumble, But if you have the insight to understand why you jump to this conclusion or why you make these assumptions, you can gradually over time chip away at some of those negative assumptions, negative thought patterns you have, and consider other options and do things differently. So if someone asks me to do something and I only do that, I don't assume that they're trying to take advantage of me. I only do that. And I only do what they asked. And I work with myself not to feel guilty about not doing more, because I would normally do more and then get mad that I did more and pin it on that person for making me do more. And they didn't. They only asked for this. So that's my long explanation for how you develop more productive coping mechanisms, more adaptive coping mechanisms, because coping mechanisms or defense mechanisms are ways that we deal with internal distress about things. And I think and managing that also has to do with your threshold for distress. So if you're easily distressed about something, it's not just about having a good coping mechanism to deal with that distress, but it's about changing your mindset about someone or yourself so that there's less upset, there's less distress as you kind of step through life and have situations and issues and conflicts. All right. I hope that helped. Amo, I just wanted to pop in to say we greatly appreciate you, Dr. Marks. Thank you, Amo. Thank you. I enjoy being here. Omar, got to get to work. Thanks for everything. You're welcome. You can catch this on the replay and see what you missed. All right. Liz says, and happy work for you. Liz says, Dr. Tracey, thank you for explaining everything so clearly and detailed and for sharing your knowledge. So nice to know there are intelligent and sensitive people like you out there helping others. You are welcome, Liz. This gives me a lot of pleasure. And make these kind of live videos more frequently. Thank you. I was actually going to ask or suggest that people put in the chat or comments whether or not they want more of these. I'm planning on doing one more in March, on March 13th. I might as well just go ahead and make that announcement. And then, because I had committed to do 3. And I said, I'm just going to see how this goes because, yeah, I don't normally do live streams. I'm going to see how this goes and how well they're received. And if people like them, then I can do more in the future. But I'm definitely going to do one more in March. And let me know if you guys like this. Jennifer, thank you for the super chat. Thanks, Dr. Marks, for all you do. Could you please share how to work with depression for those who are COVID cautious, battling COVID, and suffering from long COVID? Thank you. Okay, let me ask that again. Share how to work with depression for those who are COVID cautious, battling COVID, and suffering from long COVID. Okay. So I'm not sure, Jennifer, if you mean work with a person who is depressed or work with your own depression while having COVID. I actually, speaking of my newsletter, my newsletter today was about long-term COVID and a finding that many people with it were shown to have depleted serotonin levels, and that there may be a connection then between COVID and its effect on serotonin, and that being a basis for extending out the long-term COVID symptoms. Now, naturally, a question from that, or at least in my head, was, okay, does that mean then that maybe the use of serotonin-enhancing antidepressants could improve long COVID? And I do think that's part of people's question that's being investigated. That would be wonderful if that was a good answer, because I know long-term COVID has been a huge problem for a lot of people. And it affects people differently in terms of depressed symptoms, but also memory issues, or even things like still having the smell and taste issues or gastrointestinal issues. So long COVID, there's a lot to long COVID, and I don't fully understand all of it, but that was a finding that I saw recently, that I shared with my email community, but that I thought was interesting, and I want to be following it because I want to see if it looks like that could be a solution. But back to your question though on dealing with depression if you're COVID cautious, or dealing with COVID, I think that there really is not a magic answer to treating depression. I'm not sure if I'm answering the question that you really have, but I'm giving a stab at it. Treating depression in the context of also being sick with COVID, because COVID itself, as we have seen, can affect many body systems and cause its own issues. I think that if you are someone who who previously had depression, a depressive illness, as you know, depression is a recurring illness normally. About half the people can have an episode and never have one again. But for most, or half at least, it comes back. It can come back years later. It can come back months later. So that said, if you were someone who has had depression in the past, but then you get COVID, you can have a relapse of your depression symptoms, either just by chance or because of triggered by getting sick with COVID. And I don't know enough about the treatment for COVID to know if treating it with something like Paxlovid has been shown to also help with any mental symptoms. I mentioned that study or finding with the low serotonin thing as a possibility that maybe increasing or adding a serotonin antidepressant may help. I would love it if that's the case. And, I may try that if I have a patient who ends up with some long COVID depression, but most of the people that I treat are either already on something, and I just haven't had the opportunity to see someone who's got COVID, now newly depressed after COVID, to see if, and I probably would just treat their depression, whether it's from COVID or not. If you're COVID cautious, though, I'm still kind of not sure where that fits in on dealing with being depressed. Yeah, I'm not sure. Maybe you could clarify a little bit if you can get back in the chat to clarify what you mean by that, COVID cautious, and whether you're talking about helping someone who's depressed if you're COVID cautious or if it's your own. Donna Reed. Hi, Dr. Tracey. Thanks so much for your videos and knowledge. Can you recommend books on ADHD in women? Ooh. The short answer is no, I can't recommend a specific book. I know there are lots. I just don't have one off the top of my head that I know about. I know there's a lot of discussion around women presenting differently, or not being diagnosed as much as boys or men, because of a bias, kind of an inherent bias in the symptomatology being more skewed toward males, particularly I think the hyperactive symptoms. But recently I was on a website that was just talking all about that, and I can't remember what it was. I'm sorry. I do a lot of searching and scanning and stuff, and I don't always write stuff down. Age O Truth. I love that avatar. Love you, Dr. Marks. Came in late, but please have more of these live chats in the future. Okay, thank you for that vote. Thank you for that vote. All righty. Matto thinks. Another super chat. Thank you, Matto. I really appreciate you. Hi, doctor. I'm diagnosed with schizoaffective but have doubts. It was changed from bipolar. I've only had one psychotic episode 16 years ago, occasional mania. Is it common to only have one psychotic episode with schizoaffective? My doctor is very vague. I'm on Abilify. Great. Thank you for that question. Kind of similar to that, like, what if you've only had one manic episode? So schizoaffective disorder is like a combination of schizophrenia and a mood disorder, whether it be unipolar depression or bipolar disorder. The criteria is such that you have the presence of psychotic symptoms and then the mood symptoms. So let's just say if you're schizoaffective bipolar type, okay, so that's how it's termed, schizoaffective depressed type or bipolar type. If you're schizoaffective bipolar type, the idea is that you have psychotic symptoms that meet the criteria for schizophrenia, and you have mood symptoms, and then so you have, your bipolar disorder, bipolar symptoms, and that can happen at the same time that you're psychotic. But you do have to have a period of, I think it's at least 2 weeks, long time since I looked at the criteria, but I think it's 2 weeks, where you have just psychotic symptoms and no mood symptoms. Because otherwise it could be difficult to tell the difference between someone who's psychotic because of their bipolar disorder. With bipolar disorder, whether you're depressed or manic, you can be psychotically depressed or have psychotic symptoms when you are manic. So if you don't have this period with no mood symptoms and pure psychosis, then it could just be psychosis from your mood state, whether that's depression or mania. Now here's another distinction. With schizophrenia, because I mentioned it's like a combination of schizophrenia plus bipolar disorder. Schizophrenia is more than hallucinations or delusions. You have to have at least 2 different kinds of psychotic symptoms. And the kinds include hallucinations. So you see things, hear things, feel things, which would be tactile, I guess, hallucinations. Olfactory hallucinations, very unusual, but that's smelling things that don't exist. And then gustatory is tasting things that aren't, when you're not really, don't have anything in your mouth. Those 2 are kind of the least common, but visual and auditory, hearing things, those are the more common. That's one. So hallucinations, delusions, believing things that are not true or just not plausible or aren't real, despite evidence to the contrary. And then a thought disorder. A thought disorder is when someone's thinking is disjointed in a way that makes it hard for you to follow their train of thought. And they may have trouble even following their train of thought, or thoughts just drop off. So on the receiving end of someone who's talking to you who has a thought disorder, you may ask them a question and they say something that sounds like it's kind of related to what you asked, but not really. Like I could say, where did you go yesterday? And they could say, well, yesterday is, yesterday. And the train went down to the station and, went into, they could be like quoting some song or something. And you're like, wait, what's that got to do with anything? But in their mind, yesterday they did get on a train and they went somewhere and then they came home and, watched some television. But you can't tell that from them just saying, yesterday once more and, the train left the station. Like that doesn't make any sense. In their head, it makes sense though. And it could be a lot of stuff like that, like these kind of, we call it tangential thinking. It's like tangentially related. It's kind of related, but not, it's off. And then so that's the third thing. disorganized thought, which is reflected in disorganized speech, and then grossly disorganized behavior. So this could be, the person's pacing a lot. They are, kind of a classic example, smearing feces on the wall. Like, why do people do that? It's because, something in their head is making them kind of use it that way, kind of like artwork. Poorly taking care of themselves. I mean, the disorganized behavior is pretty disorganized. It's not just, oh, I lost my keys, disorganized. All right, so those are kind of the four major categories of psychotic symptoms. For schizophrenia, you need two. So with bipolar disorder, people, if you get psychotic, you may not have two. You may be delusional, and you may see some things. So you could have two, but it's not you don't always, and you don't always get psychotic with mania or depression. That's an intensity severity issue of that particular episode. Severe depression can cause psychosis. And severe mania can cause psychosis. So I went down a rabbit hole a little bit, I think, but I think your question, can you pop that question up again? It's been a long time, so you might not be able to find the question, but schizophrenia. So, oh, I know. Yes. Put up. I think that was it. It was about schizoaffective disorder. So I guess without having the question come back up again, how would I know that someone really has schizoaffective disorder? You were saying that you're not quite buying it. Oh, I know. You only had one psychotic episode. So is this really, yeah, there we go. One psychotic episode 16 years ago, and occasional mania. Yeah. So it's not common to only have one psychotic episode. In fact, I think it kind of goes against the diagnosis, because with schizoaffective, you remain psychotic in the absence of bipolar or in the absence of the mood symptoms, whether it be depression or mania. You still remain psychotic. And people with schizophrenia, they remain psychotic. Now it might be kind of low level psychosis, like they're still delusional, but they may not be talking about it very much. Or they're still, they may be actively hearing things, but not really talking about that either. It's not bothering them that much or something. So, yeah, if you have no psychosis, if you've never had psychosis again, I would say, yeah, it's unlikely that it's schizoaffective and just maybe bipolar disorder, that where you have some extremes at times. Abilify is a great drug for all of the for both your mania and your depression. So yeah, that you could be treated just fine with Abilify. All right, Ms. Martian. Thank you, Dr. Marks, for all your work. I appreciate your videos, which have assisted me greatly since I stumbled upon your channel. Thank you. I'm so glad. That's the goal. Paulina, greetings from the Netherlands. Wonderful. Thank you. I guess you're probably the afternoon for you, I guess. AM, what's your advice for someone who wants to do psychology? So I'm assuming you mean study psychology. If that's what you mean, I say go for it. I mean, so psychology, I guess the pathway toward being a psychologist is different from being a psychiatrist. So I'm a psychiatrist. I'm an MD. I went to medical school 4 years, and then And as I mentioned from an earlier question, I majored in electrical engineering. So I didn't know that I wanted to be a psychiatrist, and that's okay. I didn't have to be to go to med school. You can kind of major in whatever you want. But because I was not pre-med in college, then I did like an extra year after college to take all the pre-med requisites, like biochemistry and some things that I didn't take as an engineering major. Okay. 4 years of med school, you pick a specialty. I picked psychiatry, did 4-year residency in psychiatry. I did an additional year of forensics training, forensic psychiatry. So it's called a fellowship training after residency. There's lots more subspecialties now, child, adolescent. Well, that's not new, but child, adolescent, addiction, psychosomatic. I mean, there's lots of different fellowship options past general psychiatry. So that's the psychiatrist track. Psychology, on the other hand, you can get a bachelor's degree in it. I had several friends in college who had bachelors who majored in psychology. But then after you get your bachelor's, you can then get master's and then doctorate level to be a clinical psychologist. I was about to say psychiatrist, clinical psychologist. You have to have a doctorate level and then a certain amount of hours in clinical work to then get the, certification or whatever it is they call it, to be considered a clinical psychologist. If you don't get your doctorate and let's say get a master's, you could work as a therapist. And those kind of master level designations can be LPC. We had, I'm sorry, I don't remember your name. Someone here's, saying hello. She's an LPC, which is licensed professional counselor. There's also marriage and family. It's like LMFT or something, licensed marriage family therapist. And then I think there's another one, but you can get a master's level in psychology and then get also the counselor or therapist designation or licensure still requires a certain amount of work, like clinical, like supervised work that you have to do a certain number of hours before then you can get your license. I think that you can have your own practice as a licensed therapist. Psychologists who work in schools, I'm not sure what their qualifications are, like what's required for that. If you need the licensure, not sure. You may just be able to work as a school counselor if you have a master's degree. I'm not sure about a bachelor's, like what kind of work you can do with a bachelor's in psychology. So that's my thought. I think that, there's a lot of overlap between psychologists and psychiatrists when it comes to therapy. One of the kind of the main areas where we deviate would be like psychiatrists. We get very little training on testing. So like someone needing psychological testing for, say, ADHD and documenting that kind of testing, or neuropsychological testing, documenting certain cognitive issues, and intellectual testing, like IQ testing. We don't get any training in that. And then the psychologist, but we can prescribe medication. Psychologists cannot, unless you're in a state that allows for psychologist prescribing privileges. So anyway, that's my thoughts about psychology, but it's fascinating. I love it. All righty. Stan Grande. Thank you so much for the super chat. Hi, Hi, Dr. Marks. Do you think media technology has increased ADHD? Also, how do you deal with feeling like you are just lazy when you actually have a diagnosis? Yeah, thank you for this, Stan. So, keep that question up a minute. I wanted to add one more piece to the question about psychology, and I was kind of making the distinctions between the two. I think I saw this in a comment. Psychiatrists do get training in therapy. It is a required part of our training. Like we have all these little things that are required for a training program that we have to have been exposed to. So I just wanted to put that out there that psychiatrists do get training in therapy. Many, once they start practicing, won't do it, especially if they are in a practice where they take a lot of insurance, because insurances usually don't reimburse very much for therapy. So the practice or the company controlling the practice will have the psychiatrist just do medication management and then have like master's level therapists do the therapy. But that's a choice they make not to do therapy. Okay. Anyway, so going back to media technology increasing ADHD and dealing with feeling like you're lazy. So, Stan, my own personal opinion is that I do think that media and technology has worsened, I guess, worsened ADHD, not, certainly not caused it in someone who doesn't have it. But I think generally speaking, as just a collection of people, it's reduced our attention span and ability to have patience to like listen. I mean, there's probably plenty of people who like may have clicked off this video in the first 2 seconds because I didn't say something shocking when I first started. So I do think our collectively our attention spans have lessened because of things being fast, quick. You just have short attention spans, and it's getting shorter and shorter. Short form video plays to that. So now if you're only used to watching something for 30 seconds, how in the world are you going to get through this hour and a half live stream, or even a 10-minute video for that matter? I also think that on a different kind of level, the use of our phones and things has made it harder for us to not feel like to go unstimulated. And I'm guilty of it myself. I'm at a traffic light. Instead of just sitting at the light, waiting and appreciating the environment, practicing mindfulness, appreciating and what's going on in my environment, I feel like I need to look at my phone. I'm in Georgia. I can't pick it up and put it in my hand without getting a ticket. So I don't do that, for the record. But I can have it in a stand and start tapping on it to see if I got any texts or something. Like 30 seconds at the light, and I can't just sit there. If I go somewhere, I take my mom to a lot of doctor's appointments. I take my backpack and my laptop. I cannot sit in that waiting room and do nothing. Like I have to feel productive. I think that's an artifact of decreasing of lots of information, lots of stimulation, being overstimulated and feeling like we have to stay stimulated all the time. I go to a building, downtown Atlanta, get in the building or get in the elevator, and there's a television monitor. So we can watch television in the elevator. It's 10 seconds to get to the next floor. Why do I need to watch television? So it's like, I think these things just kind of are getting built into our system, and it's training us to need to be stimulated all the time with some kind of information, something spectacular and all of that. And I do think that worsens our attention spans as a whole, but then also worsens symptoms of ADHD for people who already have trouble staying focused on one thing. Now you're being trained to need to have something new going in order to keep you interested. And then show me, Daryl, the question again, because I forgot. It was a 2-part question. Oh, dealing with feeling like you're lazy versus having a diagnosis. So Yeah, this is tough. It's going to take a lot of self-talk. So in the absence of therapy to help address your personal narrative, the things that you tell yourself about this, because part of it is what people say to you and part of it's what you think about yourself. If it had nothing to do with what you thought about yourself and it was all what people said, you could fight against that by just kind of blowing them off. But you internalize it because of what you also think about yourself. And it's easy for someone with ADHD to feel flawed, to feel not enough because of the struggle. Things that other people can do easily, you can't do. You get an assignment and someone says they read a book in 2 days or read this thing in 2 days. I know I'm a slow reader and I'm like, this isn't, I don't know how you do that. I can't read. I'm having trouble after 2 paragraphs. But I'm an adult, full-grown adult now, and I can get over that. But the messages you can get as a child, seeing the discrepancy between other people's capabilities and yours, can make you feel like you're the one with the problem. You're less than. You're not good enough. You're not very smart. All of that stuff. If you're an adult now, you've got some work to do to overcome or to undo all of those negative thoughts you have about yourself, that you're not good enough at something just because of laziness. And even if you didn't believe it was laziness, you could still struggle with this of just the flawed idea, like there's something wrong with me and not being good enough. So whether it's lazy or just inept or inadequate, I think both of those messages negatively affect or can negatively affect the person with ADHD and affect how you respond to or react for future decisions. Like, I may not put myself forward for some position because I don't believe I'm capable, because I'm not very good at this, or I lose stuff a lot, or I can't be trusted for this. And especially if people reinforce that by telling me that they can't rely on me for something. And I want you to be able to rely on me, but you can't. I mean, I know you can't because I keep messing up. I keep being late, or I keep doing this, or I keep forgetting, and that kind of stuff. So I guess the long answer, or the short answer to a long explanation is, I think overcoming this negative self-talk that you're lazy is going to require not only working on your own your narrative and your self-talk and correcting your self-talk and giving yourself some grace and self-compassion, that you have an issue that makes you struggle in certain areas. And these aren't you have certain parts of you that are not strengths. And you've got to play to your strengths more than your weaknesses. The weaknesses are consuming you and holding you back. How can you be in a place that utilizes your strengths, and your strengths help you do well in that position? And that could mean changing your career path. It could mean changing the people you hang around, because or activities that you get involved in, people asking you to do stuff, you're volunteering and you're doing a bad job of it because it's not your strength to do whatever this is. But let's say you recognize, okay, I can't volunteer for XYZ because I'm not organized enough to do that and deliver it on time. You could still feel bad so you get strong and say, okay, I'm not going to volunteer for this stuff, but you still beat yourself up because other people are volunteering, and what's wrong with you? And you can let people convince you that it's because you're selfish that you're not volunteering. You say, well, I'm not volunteering because I know I won't do a good job. The person who doesn't understand can be like, well, just do a good job. You know you can't do a good job, then do a good job. And blame you for something that is something you're unable to do. But then you could still beat yourself up for being unable. Like other people can. This is something basic. Why can't I do it? So part of the intervention here is working on your own self-talk and giving yourself permission to not be good at stuff and it not being such a negative that it takes away from your self-esteem and who you are, who you believe yourself to be, which is an individual who has strengths. We're not all strong in everything. No one is strong in everything. And it just might be that, the strengths that get attention are the ones that get praised. And it just might be that the strengths you have are just not ones that get attention and get praise. And you're going to have to get used to feeling fulfilled from the things that you do well, even though they may not be the popular things that people do and get attention for. That's one thing. The other part, though, is navigating or trying to minimize your exposure to the criticism. So, as I mentioned, it's kind of two-pronged. One is what you think about yourself, and the other is what people are, the feedback that people are giving you. So if people are telling you that stop being lazy, just do this. You telling yourself, I'm not lazy, I just, I'm not good at initiating. That's not going to be enough if this is somebody you live with, work with, close to, and that's their judgment of you because that's their experience, that they're having to do all this stuff because you won't do stuff. Then you've still got to deal with that interaction. And dealing with that interaction could be helping this person see that, okay, it's not that I just don't want to do this because I don't feel like doing anything. It's I struggle with motivation, or I struggle with confidence. And so I'm not wanting to just kind of jump in and do this. And that's why. Then maybe you and that person could have a discussion about how you can help meet their needs in a way that plays to your strengths again, going back to that issue. And I'm kind of thinking about like a couple, partners, husband and wife, live together, partners, whomever, but people who you do, where the other person's needs matter. It's not just you saying, well, this isn't my strength. So, oh, well, you go do everything. No, that's not going to work for that other person because they have needs too. So if, let's say, your partner calls you lazy or considers you to be lazy because you never take the initiative to do whatever, plan a date, take out the trash, cook dinner, whatever it is, you feeling better about yourself is also going to need to involve negotiating with your partner on how you can help them meet their needs in a way that is easier for you to do, not because of just low effort, but it's easier for you to do because of it plays to your strengths. So let's say your partner says something like, well, I don't want to be the one who always has to think of what we're going to do this weekend. I wish you'd take some initiative here. And your answer just can't be, well, I'm not good at it. It's not my strength. So you do it all the time. But if your partner understands that it is a lot of work for you, but it is a lot of work for you and you're not good at it, you can maybe come up with a compromise that, okay, you're going to have to buck up and put that effort in sometimes, but not as often as you would be expected to if you never had this conversation. So, okay, once a month, I will plan out, I'll put on my, in my notes app or some kind of reminder that I'm going to go and look up some places that we can go this weekend. You hate it because this isn't your thing, but okay, but you're going to do it because of your partner. I'm going to do this thing. And that's my contribution for the month. Meanwhile, the other 3 weekends, your partner's doing it, and your partner's okay with it because your partner knows that, okay, at least you're trying. You're doing something that goes against the grain of yourself. I know, I appreciate that you're putting in extra effort here. And because of that appreciation, I'm not going to expect you to do it every week. But now at least I understand that you're trying. And that's all I care about, is that you try sometimes and not just let this all fall on me. That's kind of an example of how getting past the lazy, the lazy label will require adjusting how you think about yourself, giving yourself some grace and compassion, getting past believing that you're less than or a failure, or yourself believing that it's laziness, and that, I have a disorder that impairs my ability to do this and this, but I can do this and this. So I'm going to try and do more of these things over here that I'm good at. And that's kind of like your goal. The road that you go on is maximizing your strengths in order to take the sting out of not being good at your weaknesses. That's part one. And then part two is there will be times, or the part two is addressing situations or modifying situations so you get less negative feedback that plays into that reinforces your own negative self-talk. So those situations could be, a partner being mad, someone at work being mad because you're not doing something, and seeing how you can either do something else that makes them feel better about you, or just having to, like, on a lesser scale, do some of these things that you don't want to do because you're trying to make someone else happy. And that's important too for relationships. All right, long answer. I'm a long answer kind of person. All righty. Kimagisha, watching from Uganda, East Africa. I have learned so much from your videos. I'm so happy to hear that. Thank you. Get a sip of water. Zach and Mom. Is that Mom? Thank you so much for your consistent contribution to the mental health field. I learned so much from you as a psychotherapist and really life mental tools. Thank you. You are so welcome. Very welcome. Dr. Marks, thank you so much for your videos. I highly appreciate your advice and insight. Greetings from Canada. Thank you. Greetings to you from Canada. I hope you're staying warm. All right, we have another super chat. Wowee, no place like cheese. Thank you so much for your generosity. No place like cheese. Hi, Dr. Marks. Your videos have been very helpful for me and my friends. Ooh, thank you so much. My question is this: heart rate goes up when taking Adderall, right? If so, will heart rate eventually return to baseline if Adderall is taken long term? Good question. So any of the stimulants, I was going to say particularly the amphetamines stimulants, but the methylphenidate can do it too. Any of the stimulants can increase your resting heart rate, okay? And that increase is normally while you are taking the medication. So if you took it, say, twice a day for 7 days a week, it might be that your resting heart rate only goes down to, say, or it only reduces to the baseline while you're sleeping. And you don't really know that because you're sleeping and not measuring. And then you get up in the morning, you take your Adderall again, and then the baseline goes up. Now, the caveat here is that how much it increases varies from person to person. So you may see no increase in your baseline heart rate, or you may see a lot. So if, let's just say, the average inactive to moderately active person's baseline heart rate may be, let's just say 75. 80 would be more like on the higher level, but still considered normal. But let's just say 75 is your baseline. And you take Adderall on a regular basis, and now it's 78. Well, okay, yeah, that's higher, but how much higher is that really? How significant is that? Could getting on the treadmill 5 days a week bring that down? It might. So exercise, cardiovascular exercise, and increasing your cardiovascular fitness can reduce your resting heart rate. So runners typically have lower resting heart rates, even below 60 beats per minute, which normally under 60 beats per minute would be considered bradycardia, or a slow heart rate, which would be abnormal for someone whose resting heart rate's normally 75. But for a runner, their resting heart rate may be 40 or 45. And it's just something that, it's just because of their level of fitness and their heart, what's the word I'm looking for? I'm blanking on it, but being very efficient in its pumping. So where was I going with that? Long-term effects. So I don't know. Thank you for popping that back up. Will it eventually return to baseline? So it's my understanding that yes, if taking Adderall regularly, and I mean regularly, like most days, increases your baseline heart rate, resting heart rate, and you stop taking it, it should return it to normal. Like it should return to normal, because it's like, if you think about it, it's kind of like turning up a dial on an engine. So you take your Adderall, you turn up the dial, and everything kind of goes a little faster, and it stays that way. The Adderall wears off, the dial goes back down. And again, that dial may go down while you're sleeping, so you're not aware of the difference. Then you take your Adderall again, goes back up. If you stop taking Adderall, it's like there's nothing to keep the dial up anymore, so it goes back down. I'm not aware of Adderall or stimulants. I won't just pick on Adderall. Stimulants making permanent changes to your heart to make it just beat faster on its own. Like this is an external influence, and then you remove the external influence and things go down. So that's my answer to that. I hope that answers your question. Thank you for that. All right. I was about to say chitlins. I'm in the South where we have chitlins, but this is the chill turns. Okay, chill turns. Thank you for your super chat. Hi, Dr. Marks. Greetings from London. So you may not know anything about chitlins, which are pork intestines, by the way. Great to be in another Q&A. Can I ask, there is a link between ADHD and tinnitus, something I'm currently battling with. Thank you. Okay. Is there a link between ADHD and tinnitus, which is ringing in the ears? That's what tinnitus is. I have to say, I'm not aware. Doesn't mean the answer is absolutely no, but I'm not aware of the disorder of ADHD causing tinnitus. More than likely, it has more to do, it could be medication that you're taking. And I think there is that tinnitus may be a side effect of Adderall. I would have to look that up, but there's a lot of medications that can cause tinnitus. Some of the antidepressants. So I wouldn't be surprised if the stimulants could cause it. Keep in mind, though, tinnitus, there's lots of things that can cause tinnitus. If you have any kind of damage to your auditory organs, so, the little hair. So
our main auditory organ, and I'm cochlea, I think I'm forgetting the name, but anyway, there's like these little hairs on it that detect sound and things. And we lose those over time when we get exposed to really loud sounds. So, and also just over time in general as we age. So exposure to loud noises, even if they are not necessarily like you don't feel ear pain. Like I went to a conference not too long ago and I walked in and it was so loud. And my phone even had, my health app on my phone even had a warning, you're over 80 decibels or something like that. It said, now my ears weren't hurting, but it was too loud and unpleasant for me. And I thought I'm losing ear hairs. My hairs are dropping off inside my ear because of this. So I guess what I'm saying is, so an effect of, say, ear loud noises, and kind of ear, I don't want to say damage, but I guess damage for lack of a better word, hearing issues, exposures to loud sounds can also result in tinnitus that comes and goes, or comes and then goes away. And then inner ear issues, I think, can also cause tinnitus. So there's multiple reasons for tinnitus, but my guess would be more of either environmental factors like sound and your exposure to noise, or something with your ears, or also environmental, with medication being in that environmental contribution, like something external to your body versus a condition like ADHD causing tinnitus. I doubt that. I don't know for certain. I've never seen anything like that before reported, and I doubt it. Thanks for that question. Anonymous Wallflower says chitlins are the best. I think I've only had them once, and I just kind of forced myself. I don't like that texture because it's intestines and they stink up your house, something awful. All right. Linda says, hi from Denmark. Hi, Linda. Greetings from Barbados. Thank you so much, Barbara. I love the international influence here. We do have quite a few people who watch this channel not from the US, and I really appreciate that. Mangela says, thank you for sharing all this information with us. You are so appreciated. You are welcome. AD says, appreciate your long answers. You are such an awesome teacher. You have one of the best channels on YouTube. Thank you. Thank you. Thank you. All right. Murthy Parmarthi says, thank you for the super chat. Does too much exercise trigger ADHD? Too much exercise? I doubt very seriously. And this actually reminds me of something I didn't answer in a previous question, the question about keto diet, intermittent fasting, and exercise. So the exercise, sorry, it's disjointed because I'm just now giving this like part 5 to the question, part 5 answer. And I will answer your question, Murthy, a little more detail. Exercise makes us feel good because we get lots of things that happen. You get, so it used to be thought that it was endorphin release. Well, you can get endorphin release from intense exercise, kind of the thought to be the runner's high thing, but that's not, now we see that that's not the major thing that happens, because it takes a really intense level of exercise to get that kind of release. And that release of endorphins is thought to be more for the body's protection of like damaged muscle tissue and stuff like that from the high intensity of exercise. We also get release of endocannabinoids, which is our body's marijuana system of producing the cannabinoids. So that's really where we believe this good feeling comes from exercise, that that cause some level of exertion. So it's more than doing push-ups. It's generally thought to be related to more aerobic level. But if you do like HIIT workouts where you do high intensity something, it doesn't necessarily have to be on a treadmill, but high intensity something, then take breaks, like that could also produce that effect. And then the other way that exercise helps us have the sense of well-being is by triggering or stimulating the BDNF system, brain-derived neurotrophic factor release, which is a protein that in the brain that helps with pruning bad neurons that kind of need to be removed, and repairing poor connections and things like that. So and regrowing nerves. So that's also where exercise helps. And I do have a video on my on this channel talking about talking about exercise and its impact on the brain. So, okay, that's my last part of that question that was probably an hour ago. So back to, can you put up the question again? Too much exercise triggered ADHD. So ADHD is a very complex disorder. So the answer is no. At least I don't think so. But here's the explanation. So where we think some of the difficulty comes with ADHD is in dopamine production in certain parts of the brain, not everywhere in the brain, because dopamine is produced in different parts of the brain, and some of it affects movement and things like that. But in the prefrontal cortex, you get in certain dopamine pathways, you get less dopamine release or production. That's thought to affect the executive functions and focus, concentration, all of that. So, exercising, if anything, I kind of answered it a little bit with the BDNF thing that I was bringing up, answering that other question, is exercise is a good thing when it comes to improving brain health. So if anything, I would expect that exercise with the increase in release in BDNF would help with tighten up some of these nerve connections and things in the brain, which in general is a good thing. Nerves that, so communication in the brain comes from signals starting in one point and traveling to another point. And so it goes, these are like nerve endings, like, where am I here? Okay. So, a signal may start here, travel down the nerve, and then here's another nerve, and they connect, and then it keeps going, and then it goes to another part. And so like all these connections. Okay. When you get loose connections, kind of like, an electrical circuit. I was an electrical engineer. I guess that's why I think of this example. But if you get loose wires and stuff starts shorting out and doesn't work. Okay. So same thing in our brains. So I would expect that exercise, we know that it can help with depression and anxiety. I would imagine it also help with ADHD. I don't know the exact mechanism of like what gets affected to then help. But if you just think on more of a broader level of helping with wiring and circuitry and nerves connecting nicely together and all of that in the areas of the brain that are affected by ADHD, then exercise should help that way. If you're thinking about the person who has ADHD who is hyperactive and could making them run around the block, make them more hyperactive, no, it actually might help settle them down, getting some of that energy out. So, but no, I wouldn't expect that like making someone, if someone was exercising a lot, that would make them too hyper they might get pumped up and feel really good, but not make them hyper from a ADHD condition perspective. All right. Well, we're coming to a close. If there's one more question that's already out there, I'll answer that and then be done. If not, oh, okay, one more. Brian, thank you for the super chat. Hey, Dr. Tracey, are you familiar with nonverbal learning disability? I am currently diagnosed with a disability where I struggle with visually processing information in regards to my visual working memory. I cannot remember anything visually. Yeah, so Brian, my knowledge of this is limited because the learning disabilities are normally diagnosed in childhood. And this would be something that would be, the intervention for it would be learning related, like, learning how to strengthen the things that you're not good at. For some children, they may never get to the point where they're good with visual processing. So, okay, you make accommodations. So some children will require certain learning, educational accommodations that if, say, that they don't take classes or get excused from work that requires them to learn, because the only way they can learn is if, the teacher's presenting in this way, they're not going to be able to receive that information as well. They may also need some audio thing that they listen to or something. I'm just kind of making this up, but that's an example of how knowing about this problem or issue can get past it or work through it by having certain accommodations so that they can still develop normally and learn everything else, but still have this issue. Now, I think where some of this can cause like broader problems other than educational is for the person who has trouble recognizing emotions. Or like recognizing facial expressions, like that can bleed over into, trouble in a working environment where people are saying stuff and the person's like, seeming to be aloof or unresponsive and things like that. And even that is something that may cause a problem, may not. And I think that, it kind of depends on your work environment. So if knowing this stuff about yourself can help you do your best to tease out or kind of or avoid situations that are going to I don't want to keep saying, drain your weaknesses, but that where this is going to be more exposed and this is going to be more of a problem for you. So going back to the example of having trouble visually appreciating or recognizing people's facial expressions and interpreting body language and that kind of stuff, you need to hear what somebody says and you take it at face value, and you cannot like factor in their facial expressions. Well, let's say I have that problem. I shouldn't work in a job where that are lots of meetings. I probably would not be able to be a good manager. Maybe, I don't know. Maybe I could be a manager where if we're working remotely, we don't have Zoom meetings, or if we do, most of my work gets done through emails and stuff. Like that's kind of an accommodation of sorts of, I know that I'm not going to get much out of these in-person or face-to-face discussions with people if at a manager level. So I'm going to need to have phone conversations or emails with people to just address the words, because I'm not going to be able to deal with emotions and faces. Or just not, or have the kind of job where I need to work in an environment where I'm mostly working by myself, work project-based, and not have one where I'm giving talks or, leading groups. Like all of that stuff isn't going to work very well for me. So So that's kind of my take on that. There's a lot of different kinds of learning disabilities, and kind of tying this back to the psychology question, like usually these things are picked up on with testing, the details of where the deficits are, what they are, and what are the things that can be improved or worked on. There are some conditions where people can improve with cognitive rehabilitation, they call it, and that can take different forms. Sometimes it's occupational therapists working with people for stuff. Other times it could be other kind of learnings or other types of skills that you learn to overcome the visual part, but being able to use other your other senses to get the information from your environment because you're not getting it visually. That gets really detailed and specific when it comes to cognitive rehabilitation treatment. So that's kind of what I know about some of these non-verbal learning disorders and some of the other kinds of learning disorders that can affect people early on and affect development a little bit, but yet sometimes still people can progress through it and improve or find workarounds, but still have these deficits and live with the deficits. But the workarounds are enough to make the deficit not be so impactful for them because they've got workarounds. And that finding those workarounds would come through either cognitive rehabilitation or through a therapist who specializes in working with people with learning disorders and how to form workarounds to be able to achieve something that they're needing to do, but they can't do because they have this thing that's holding them back. All right. Go ahead and say about that. Well, thank you everyone for coming. And if your super chat wasn't answered today, I will gather those up and see about answering them in a different way, whether it be a super chat or a separate like random video that I publish. But I will work on it. I really think people do that and not get it. So I will go through and figure out what those were. Yes, Ask Me Everything. Ask Me Anything is March 13th at 10 a.m. Eastern Time. I am in Eastern Time. And don't forget, you can go to getmentalhealthtips.com to sign up for be on my email list, and I will send you information from time to time, preferably, hopefully weekly. That's what I'm doing so far for 2024 on kind of new insights or things that come up in psychiatry or psychology even that I think you'd like to hear about and know and stay on top of. All righty, guys. Thanks so much. Have a great rest of your week. Bye-bye.